Good afternoon, everybody, and welcome to the 9th ICOD Hybrid Conference. I'm Dr. Emmanuel Samson. I'm a professor and head, Government Medical College, Mirrors, India. So, as you all know, that due to the invent of bioceramic sealers, the single pore obturation technique has become very popular, and it is becoming successful as an endodontic therapy. Now, before I start with hydraulic condensation in endodontics, I would like to brief about the micro leakage, the bioceramic sealers, its tubular penetration, the expansion, the types of bioceramic sealers, the mechanism of its action, why it is used, and what is the way to use the bioceramic sealers, and finally, how it's going to benefit the hydraulic condensation in endodontics. So, let's start with micro leakage. Now, the prevalent reason for endodontic failure is related to micro leakage due to the failure of adaptation of gutta percha and the sealer, or even for that matter, dentine. Now, if you see the SEM section, which is at the interface of sealer dentine interface at 650x magnification, you can see a space thereby causing micro leakage. Thus, micro leakage is defined clinically as an undetectable passage of bacteria, fluid molecule, or ions between the tooth and the restoration or filling material. Now, the various scientists like Gay, Schipper, and Jonathan have concluded that there is no difference between resin and bioceramic sealers on micro leakage due to bacterial penetration. Now, authors like Majid H. and Sibu Thomas, they did an assessment of the interfacial adaptation of new endodontic sealers to root dentine that was with and without gutta percha cone. The conclusion they got was WireSeal sealer showed high interfacial adaptation with compared to endosequal BC and MTF fill apex. So the interfacial adaptation after filling the canal with sealer alone was higher than with the main cone. The sealer alone had shown a very high amount of interfacial adaptation. Now, regarding the sealer shrinkage and expansion. Now, as you all know, even in 1950s and in 1960s, single cone obturation technique was used with a 2% gutta percha. But however, with zinc oxide eugenol, however, due to shrinkage, now as in both the studies, you can see the shrinkage of zinc oxide sealer was 0.9%. Thus, internal shrinkage as well as external shrinkage of zinc oxide eugenol was seen, causing an endodontic failure. So if you see expansion and shrinkage of popular sealers and bioceramic sealers have been shown above. The BC sealers expand slightly on setting, which is 0.25%. And the pre-mixed bioceramic sealers are hydrophilic. They do not shrink and are insoluble in tissue fluids. Both these sealers have shown antimicrobial and sealing property, the pre-mixed ones. Now, in case of sealer penetration, now if you see the SEM of dentine surface after the use of sodium hypochlorite and EDTA, The dentine surface can be seen as it is clean and the dentinal tubules are visible and patent. The picture C shows the sealer penetration into the dentinal tubules. Now, various endodontic studies have shown that age plus sealer has a maximum penetration, so as good as bioceramic sealers. Now, however, regarding bioceramic sealers, MTA fill apex followed by BioRoot RCS sealer showed 304 IQA sealer penetration, while maximum sealer penetration was seen for BC sealers, which was 475 IQA unit. Now, this is a micro CT of a single cone technique, which shows that the endosequal BC sealer may have similar sealing ability regarding the whole root canal as that of BH plus sealer. Now, both of the micro-CTs also showed that the neither endosequal BC sealer or AH plus provides a porosity-free root canal filling. A superior penetration is observed in coronal 1/3, followed by middle and axial section for sealer penetration. Now, what exactly is a push bond strength in case of sealers? A push out bond strength. The push out bond strength is used to evaluate the interfacial bond strength between root canal sealer and radicular dentine. So if you see the table, the highest amount of push bond strength is seen for iRoot SP, that is without a core material, which is 2.03 MPa, while the lowest mean push out value was obtained by methyl acrylate resin sealer without a resin with a resin core material, that was 0.94. Now, what are the various bioceramic sealers available in the market? In brief, they are available in two components, in various two types. There are, first one is a premix. Mixed. Now, in that we have natural, which is known as endosequal MTA, and pro-root MTA is in case of non-premixed. Now, in case of synthetic, we have endosequal BC sealer, we have iRoot SP, total fill BC sealer. The first two are mostly available and marketed in UK and US. However, in case of Indian subcontinent, we have Endoseal TCS, which is by Meta Bioseal, and a double mix we have is BioRoot RCS. In India, we have Cerasil B. So these are the classification of BioRoot canal sealers. Now, what are the properties of BioRoot canal sealers? Basically, before we start from MTA in brief, Portland cement was the parent component of MTA sealer. It was refined, particle size was decreased, the toxicity was removed. The first lecture of the Portland cement was being given by Dr. Wright, a German scientist, in 1878. Later on, a scientist known as Dr. Torabinajan developed it, and it is now got an FDA approval in 1998. So if everything started from MTA Fill Apex is one of the brands, followed by BioRoot RCS and BC sealers. These are currently used in the market. So if you see the solubility, the MTA shows the least solubility, that is 1.76%, while followed by 11, that is bioroot RCS, and maximum 12% by BC sealers. The pH, which plays the important role in case of bioceramic sealers, it is 8 for MTA, bioroot RCS is 11, and maximum showing 12 for BC sealer. Now, however, radio opacity, MTA had a maximum amount of radio opacity, which was 5.5 mm per aluminum. Depth penetration, which is important in case of micro leakage, or which is important in case of success, in case of endodontics. MTA showed 202 mm, while bioroot RCS showed 304. IQR is the unit, and maximum sealer penetration was seen for BC sealers, that is 4.75 IQR. Now, there has been a sudden paradox shift in use of endodontic sealers. Now, if you see the traditional method, a more amount of gutta-percha were used and less amount of sealer. Now, in fact, the sealer was just used like a lubricant for obturation. But in case now with the bioceramic technique, a more amount of sealer is used. Now, initially, the sealer lacked the property. They had disintegration, they had solubility, but this had overcome in bioceramic sealers. Thus, the volume of sealers in bioceramic technique is more. It is a sealer-based obturation technique with very less single gutta-percha cone. That also used as a plugger, or in case of used in case of re-root canal treatment. Now, why you want to use bioactive sealers, bioceramic sealers? Now, if you see the mechanism of action, it is a di or a tricalcium silicate which comes in contact with the moisture, that is and causes or moisture or water, and causes calcium hydroxide, thus provides high pH for antimicrobial activity and osteogenic response. These calcium ions, when combined with phosphate ions, which are already present in peritabular dentine, or in case of peritabular dentine, then in case of dentinal tubules, lead to the formation of hydroxypeptide crystals. Now, what is the biological outcome? The biological outcome is biocompatible, it is bioactive, it gives hydroxypeptide crystals that is going to fill the gaps. The sealer is hydrophilic in nature. It supports regrowth of tissue, that is cementum and periodontal ligament. Bioceramic sealers also favors the regeneration of periradicular tissue, a process modulated by osteogenic and angiogenic event. So at a microscopic level, if you see, the diffusion of sealer particle takes place into the dentinal tubule, producing a mechanical interlocking bond. Second, infiltration of sealer mineral content into the intertubular dentine results in a zone known as mineral infiltration zone, produced after denaturing of collagen fibers due to the strong alkaline sealers. The presence of moisture resulting in the formation of hydroxypeptide along with mineral infiltration zone can be seen at a microscopic level. Now, this article gives about the clinical use of a sealer. A very good article about hydraulic cementation cements given by Joseph Cameril, classified as intercoronal, which is pulp protection barrier for regenerative endodontic therapy. interradicular for root canal sealing, that is apical plugs, extraradicular, root end filling, such as perforations, repair, etc. Now, the term hydraulic is used to define the setting reaction, that is with water, and the ability to set and then to be stable in a wet environment, which is crucial. So how has the obturation changed? Now, initially we had a core-based obturation. Now we have a sealer-based obturation. Initially, traditionally, we used H plus sealer with multiple gutta percha and a mechanical pressure, that is lateral condensation, maybe vertical condensation. Later on, same, but we used calcium silicate sealer with single cone, thermoplasticized gutta percha, thermomechanical pressure, and in case of manipulation, it was continuous wave of condensation. But if you see now with calcium silicate based sealers, it is a single gutta percha and known as hydraulic, that is known as a pressureless technique or known as hydraulic condensation. Now, this is a tubular penetration, which only concludes that tubular penetration was higher for pre-mix sealer. So using a pre-mix sealer rather than two component sealers, it is better to go for a single mix sealer. Now, why a hydraulic condensation? Now, initially, if you see lateral and vertical condensation had various limitations, as we discussed, because of the sealers. That was an old condensation technique or old concept. Now, today we have known as a sealer-based obturation technique. Now, in this point, you see that, however, the hydraulic condensation is done at a room temperature. So neither the gutta percha is going to shrink nor the sealer. There is more micro leakage seen at gutta percha sealer interface than the sealer dentine interface. Now, as the gutta percha is hydrophobic in surface, while you see the sealers are hydrophilic material, thus there is no need for there is no natural bonding takes place between the gutta percha and the sealer, as they are different. One is a hydrophobic and one is hydrophilic. So we have a gutta percha nowadays which are BC coated gutta percha used in hydrophilic condensation. Now, what exactly is hydrophilic obturation technique? It is a basic technique and advanced technique. The sealer is placed in the sealer is delivered in 2/3 of the canal. The tip of the syringe can be removed once the sealer is delivered in the canal, both in basic and advanced. And the dispensing tip is used as a dipper, that is a reservoir for the sealer. So you can use the sealer from the tip itself of the syringe. Use the file to coat the wall with BC sealers or whichever endodontic bioceramic sealer you are going to use. A file after placing 2/3, use a file to place the sealer. The master cone gutta percha is selected. A cone matching is done. The cone is selected according either one size smaller or the same size, and the gutta percha also can be coated with the sealer, and then the obturation has to be done, followed by verification by an X-ray. So what are you going to achieve from this hydraulic condensation? The bioceramic sealers do not shrink. There is a shrinkage of gutta percha, that is 2 to 7%. The bioceramic sealers are going to bond to the dentine. They have antimicrobial property. The flow of the sealer can be used, the flow property. Bioceramic sealers are hydrophilic. The dentin tubules, we have is moist, is hydrophilic, so bonding will be better. So would like to conclude. So the initial point, the mineral maturity of BC sealers was elevated by increase in calcium phosphate content, particularly after the phosphate buffer solution. Second one, no shrinkage of bioceramic sealers is seen in hydraulic condensation technique. The gutta percha is used only as a carrier or as a plugger to place the sealer or to the full length, and it can be kept there for re-root canal treatment. The gutta percha cone impregnated and coated with nanoparticles of bioceramic thus eliminates the gap between the core material and the sealer. So these are the references. Thank you.